Hello there. Thank you very much for joining. It looks like it's a couple minutes after 12 noon. So on behalf of York Hospital, we'd like to welcome you to today's Zoom and with Dr. Michael Morwood. Today, Dr. Morwood will talk about some exciting advances in knee and hip surgery, and he will save some time to answer your questions at the end of the presentation. A few quick housekeeping notes before we get started. As participants, your audio has been muted, so if you do have a question that you would like to ask Dr. Morwood, you can type it into the Q&A button located at the bottom of your screen. Please do not use the chat or raise hand features, as those will not be monitored during this call. If you ask a question through the Q&A feature and it is not answered by Dr. Morwood during this meeting, you can call his office to schedule an appointment and get more information by calling the number you see on the screen right now, 603-431-1121. So now, once again, thank you very much for tuning in today, and we will go ahead and turn the program over to Dr. Michael Morwood. Thank you.
Well, great. Thank you, everybody, for coming today. This is a pretty exciting thing for us. The first time we've ever done this. We're very happy to be able to do this in our new coronavirus world here. We're still trying to get all the information out as much as we can, answer everyone's questions, and take the best care of patients. So, again, thank you so much for coming. I wanted to talk today mostly about hip and knee replacement, but really focus in on robotic surgery and some exciting things that we're doing in terms of hip and knee with robotics. So I am hopefully going to stop my video so we can just see the slides and we'll get going. So just a quick couple of disclosures, none of which are pertinent to today's talk. A little primer on me. So I did medical school at University of Vermont. I'm a native Vermonter, actually from Burlington. I went and did my residency at Duke University in North Carolina. And then I did a trauma surgery fellowship in Tampa, Florida, before I went to Salt Lake City to do my hip and knee replacement fellowship. So I'm actually a dual fellowship trained in both trauma and joints, with certainly a focus on robotic surgery for the joints. So what I wanted to get touched on today is a couple of different things. So basically at the beginning, we want to start with just understanding joint pain, kind of where it plays in terms of everyday activities and life, get into a little bit of the treatment options, and then the heart of the talk will certainly be on the joint replacement surgery, and especially with robotics. So that's the meat and potatoes of the talk will be during that. A little bit on recovery afterwards, and then a Q&A. I really want to make this as patient-focused, and whatever questions you all have, please, put them into the Q&A box. We'll get to as many as we can. And then, like I said, if we can't get to all of them, I'll take a look at them after the talk, and we'll send out some answers. So what I wanted to do is just start with a quick case presentation to kind of highlight what we're talking about. So here's a 59-year-old female patient who came to my clinic, said she had left knee pain for many, many years. She described a grinding type pain. This is a very common word used: grinding, gnawing, aching pain in the knee. Wakes her up at night, and she can no longer walk around the block without pain. So she used to love to go for walks. Now it's just not happening because of her left knee discomfort. So here are the x-rays, and right away you can see there's a problem with that left knee. We'll get a little bit into the specifics as we get through the talk, but basically, and I think you could probably see my mouse, this is the right knee, the space between the bones, that's where the cartilage lives, and you see there's no space left. This is just bone on bone grinding knee arthritis. Here again, you see, looking at it from the side, this is just bone on bone grinding away knee arthritis. So she underwent a total knee replacement with the Mako robotic assistance. She's back to doing all her normal activities, is walking around the block, is incredibly happy with how things turned out. And it really is a game changer for her. She's able to do all the things she loves to do again. So this is important. Your joints are involved in almost every activity you do. We know that a diseased or injured or arthritic hip or knee can certainly limit your ability to move and work. And in fact, knee and hip pain or arthritis, one of the most common causes of disability in the United States. So it plays a role in a lot of people's lives. So common causes of joint pain, there are a bunch. Rheumatoid arthritis is one thing people think of often, and this is an inflammatory condition. Most of the time it's hereditary. This is actually not the most common form of arthritis, though. The most common form of arthritis, at least in this country, is osteoarthritis. This is otherwise known as wear and tear arthritis. The way I like to use the analogy for this is basically the treads of the tires have been worn off. So there's no cartilage left, there's no bumper anymore, so the tires are gone, it's just bone on bone The wheels are still there, but the cartilage and tires are all worn off. Non-surgical treatment is 100% the right way to begin. So we try everything we can do non-surgical first to try to improve life, relieve symptoms, and get you back doing what you want to do. Walking aids certainly can help. You put less pressure on the affected joint and can give you some symptomatic relief. Heat, cold therapies also can be helpful, especially for knees. Physical therapy can be very beneficial. Most of the time when you have an arthritic hip or knee, the muscles around the joint actually atrophy from disuse and pain. So physical therapy can be very beneficial in getting those muscles back to as strong as they can be, which actually is a protective mechanism for joints. So we like to prescribe physical therapy. And then really the mainstay for medicines are over-the-counter anti-inflammatory drugs, ibuprofen, Motrin, Aleve, Tylenol, that sort of thing. And then when we get into injections, corticosteroids or cortisone is probably the most common thing we use. And again, that's all targeted to limit the inflammation that's being caused by that bone-on-bone grinding, gnawing, aching feeling. So when do we consider joint replacement? I like to run through this specific list with every one of my patients that I see in the office. Is joint pain affecting your ability to get a good night's sleep? If you're being woken up at night because of pain, because of inability to get comfortable, these are certainly things that joint we're starting to think about. Is this a time for replacement? Does the joint pain keep you from doing things you want to do? Hey doc, I used to walk 18 holes of golf. Now I've got a ride. It's too painful to do anything but that. I used to walk around the block, used to go for a 5-mile walk. Now it's down to a mile, and I'm paying for it that night. My knee's swollen. I'm not able to do anything for the next couple of days. Those are very common kind of themes that I hear from folks. Are you less active because of joint pain? Again, I used to love going for walks with the family. I used to ride my bike, used to play golf, and it's just not able to do that anymore because of this pain. And then is the joint pain affecting your ability to walk upstairs? Or is it affecting your ability to get in and out of a low seat, maybe get in and out of your car? These are all very common things that folks complain of when they have bone-on-bone arthritis of either the hip or knee. So we'll start the presentation really with total hip replacement, and then we'll blend this into where we come in with the robot. So hip anatomy, basically your hip is just a ball in a socket. Once again, if you look kind of on the right side, you see the ball with the white cartilage, and then there's the nice healthy socket. On this diseased or arthritic side, you see the cartilage is being worn away. The red kind of simulates worn away cartilage down to the bone. So that's exposed bone, that's bone on bone, very, very painful. It can be very difficult to do activities even of daily living when you have an arthritic hip. This is the x-ray version of what we were just talking about. So again, the normal hip on that right side. The space between the ball and socket is where the cartilage is. Can't really see it on x-ray, but you know it's there because the bones aren't touching. And in our arthritic hip, again, you see this bone on bone, big cyst formations in the bones here. All of this white stuff is called sclerosis. That's because the bone underlying now is seeing a ton more force because the cartilage is all worn away. So this is bone on bone, arthritic, grinding hip pain. And again, as you see at the bottom, arthritis is certainly one of the most common causes of disabilities in adults. So here's a quick little video that I'll play. It's an animation of really what a total hip replacement is. It's slightly different than a knee, and we'll get into the specifics later, but here's a hip replacement. Pulling away the muscles, again, you see where the joint is. Now, in a hip replacement, we actually remove that arthritic bone, remove the bone in the socket as well, and then there's a metal cap that goes in there. Piece of plastic between the metal cap, pin down the leg. There's a little metal or ceramic ball that goes right there. And then we reduce the hip, and there you go. That's how it works. Basically just a recreation of the ball and socket. Again, this is a little bit of a cartoon version of how it works. You see the metal socket that's in, the pin down the leg, and then the ceramic or metal ball that rubs along that plastic. So in this country alone, more than 300,000 hip replacements are performed every year, and that's only increasing. The estimates are for roughly 750,000 hip replacements by the end of 2030. So this is a problem that's affecting a ton of people and can be a very, very beneficial operation in terms of getting back to doing things you want to be doing. One more kind of version of what a hip replacement entails. metal resurfacing of the socket. You have a new ceramic ball and a piece of plastic that they rub between, and that's how you get your new joint. And this is what it looks like on an x-ray. So you can imagine that left side over here used to be an arthritic hip. We have the metal socket, the pin down the leg, and then either the metal or ceramic ball, and off to the races. So with that, we'll kind of transition into what are we doing with the Mako robot. So this is a super important or an amazing piece of technology that's really kind of revolutionized both hips and knees. And so we'll start with hip in terms of what the Mako total hip replacement does. To do that, I wanted to bring in another case presentation. So here's a 55-year-old man who came to see me, complained of significant right hip and groin pain. And this is another very common one. He said, I can't move my leg from the gas to the brake without severe pain. Every time I drive, I'm not looking forward to it because I know it's going to be painful. So we pull up his x-ray here. Again, now we know no space between the bones, bone-on-bone arthritis, sclerosis, that really dark white or the bright white stuff, kind of a square peg in a round hole. So this is hip arthritis. So we got him to go with a Mako total hip replacement, and this is how it works. Probably the mainstay of the Mako robot, honestly, is not even in the operation itself, it's in the preoperative plan. So the beautiful thing about the robot and the software is that you have a CT scan that we take before the operation. And this CT scan allows for a wealth of information. I'm able to take a look at your bone in space. 3D model is created for your unique anatomy. And then we're able to plan exactly where we want to put our implants up to a millimeter from what we plan. It's an incredible amount of technology. So this is the actual case. This is the gentleman I was just showing. This is the screen that I see preoperatively. I'm not even in the OR yet, and I'm able to plan this operation step by step up to a millimeter away. I get a ton of information. I'm able to see that his leg is 9 millimeters shorter than the other leg. Then I'm able to go in and actually map out where I want this implant to sit. I know exactly where it should be in terms of the position. I know exactly where it should be in terms of the angles that it's placed. So I get a 3D model to match this patient's exact anatomy to recreate a normal, smooth functioning hip. It's a pretty remarkable technology. Here we go now. Once I decide where I want to put my implant, I get a 3D model of his pelvis, and it shows me from a couple of different directions where the implant's going to be. This looks at it kind of from the side. This is looking at it from the front. And again, I know where I want to put this implant to both match his leg length, to get the what's called offset, or where the hip is in space, to be exactly correct and match up to his other side. This is another screen to look at the pin or stem down the femur. Again, I'm able to map this out in 3D to exactly the size of the implant I'm going to use and exactly where I want to place it. Finally, I get a snapshot with everything back together. This is what the implants are going to look like after I've put them in with my plan. So once I'm happy, we know his leg lengths are going to be equal. We're going to recreate all of the native mechanics about the hip joint, and we know the implants are going to be put in perfectly. And the way we do that is in the operating room with the robotic arm. So one of the common things that I'm asked is, well, is the robot operating? Are you operating? It's a little bit of, again, a misnomer. I'm doing all the operating. The surgeon is doing all the operating. The beautiful thing about the robot, though, is that it allows me to take the plan that I put into the computer, match it up perfectly to the patient's bone, and then it keeps me in those parameters. So when I'm doing the operation, so when we're removing the arthritic bone or resurfacing the socket portion, the robotic arm shows me exactly where it needs to be in order to perform that operation within a millimeter of what we wanted it to. So we bring the robotic arm in, and this is an actual picture of the operation where the robotic arm is being used to show exactly where we want it to be. Final snapshot of the patient once we get the implants in, and then here's the x-ray. Again, perfect leg lengths, the offset, the joint mechanics are restored perfectly. It's exactly where I wanted it to be. It's a very good outcome, and the best part is there's no guesswork. I'm able to map in a 3D real time and get those implants exactly where we want them to be. Really quick, we'll touch on a little bit of some of the muscle sparing approaches in hip replacement before we get into knees, and we'll go back into the robotic technologies for knees as well. But just one thing that I do is a direct anterior approach to the hip. For the right patient, it can be a tremendous operation in terms of slightly smaller incision, a quicker recovery time. In this operation, you actually don't need to cut any muscles. You just move them to the side. Slightly less chance of hip dislocation after the surgery. A lot fewer restrictions in terms of what you can and cannot do afterwards. Now, I do both a direct anterior and a posterior approach for the right patients, of course. The safest operation for each patient is done, and they're both tremendous operations. But definitely in the right patient population, this can be a tremendous benefit. Certainly get you back a little bit quicker. Again, a little bit of a difference between the traditional and the anterior approach. With the anterior approach, the muscles are left undisturbed. They're just moved out of the way rather than split. And there's definitely a little bit of a faster recovery, less need for post-operative therapy, and improved pain relief. So once again, for the right patient, it can be an awesome little benefit for sure. The graphic representation of what we're talking about there with the different approaches. One thing I also wanted to touch on, this comes up quite often. So I see a lot of patients, 80, 81, 82 years old who say, doc, I know I have terrible hip arthritis, but am I too old? Is this, should I have this operation? Can I have this operation? It's a fact that's been studied quite substantially. In fact, when I was at Duke University, there was a study that came out from that university that talked about the effects of total hip arthroplasty on physical functioning in the older population. And their conclusions were that seniors with arthritis who undergo hip replacement are twice as likely to show improvements in both functioning and ability to care for themselves. And again, no age limit on the benefits. So that's one of the biggest things that came out of this paper. Yes, there's some risk and benefits to every surgery. Every patient is unique, and you have to take into account everyone's individual circumstances. But again, age in and of itself is not a contraindication and should not dissuade someone from potentially having the operation. It's certainly a conversation to have. So I think what we'll do is we'll kind of continue on. We'll go into the knee portion. If any questions come up again, there's a Q&A function or a button at the bottom of the screen. And we can answer more questions at the end. So let's jump into total knee. Again, we'll start off with a case presentation just to kind of jump into the knees. Here's a 50-year-old female. She's having long-standing right knee pain. Her range of motion is 10 degrees shy of going out straight, so what we call a flexion contracture, where her leg doesn't actually want to go fully straight. And then the real big, again, the complaint is my knee gives away randomly. I never know when it's going to happen. I'm afraid I'm going to fall. The worst thing we want to see, obviously, is a fall. You can hurt yourself, break bones, that kind of thing. So this is another kind of typical case presentation. Pull up our x-rays again. Now we know space between the bones. That's where the cartilage lives. Just no space here on the outside, especially of that knee. Again, looking at the side, no space between those bones. We know the cartilage is worn out significantly. And the leg is actually pointing almost 20 degrees to the side. So it's a fairly significant deformity. We do a total knee replacement again with the Mako robotic assistance. We've got a nicely well-balanced knee. The leg is straight again. She's able to use it, doing all her normal activities, and is very happy with the result. So when we talk about the knee joint, slightly different than the hip joint. It's not a ball in a socket. It's a little bit different. There's multiple what we call compartments. So we talk about the kind of the inside compartment, the outside compartment, and then underneath the kneecap. So when we talk about partial knee replacements or versus full knee replacements, that is where that kind of stems from. And again, arthritic knee, we know cartilage is lost, bone-on-bone arthritis. Here's a good example. Here's a healthy knee. And then the bone-on-bone arthritis, you see no space left between the bones. This bright white sclerotic, very irritated, angry bone, gnawing, catching, aching type pain. The other thing we know is that for every 1 pound of weight loss, that takes 4 to 7 pounds of pressure off of the knees. So it can be fairly dramatic. Just even 10 pounds of weight loss can take 40 to 70 pounds of pressure off the knee. So the knee certainly likes to have some less stresses around it. But essentially, when you have bone-on-bone arthritis, it's a very tough thing to deal with. So once again, a little animation on how a total knee replacement works. Once again, I've said this a couple of times, but it is also a little bit of a misnomer. When we do a knee replacement, we don't actually take your knee, throw it out, put a new one in. It's a resurfacing operation. So as you can see in this demo, we just make very precise cuts all around the knee, both on the femur and tibia, and then we resurface with a metal cap, kind of like a dentist puts a crown on a tooth. All that is there is the cartilage is being now made up by that piece of plastic. So again, the types of knee replacements that we're able to do are many. We can do partial knee replacements like seen here. This is a medial sided partial knee replacement. Again, that's a scenario if the outside of the knee or if underneath the kneecap is not damaged and there's still cartilage left. Or we can do the total knee replacement if the entire knee or the cartilage of the knee has been worn away. 600,000 knee replacements are performed every year in the US now. And once again, similar to hips, the estimates are for close to 1 million knee replacements a year by the year of 2030. So this, again, very high burden in the country. Examples of knee replacements. Once again, partial knee replacement here. You can see just the inside compartment has been replaced versus over here, the entire knee has been replaced. You have the inside, the outside, and underneath the kneecap. And different folks obviously have different conditions, and that's a conversation to have with your surgeon as to whether or not you'd be a good partial knee replacement candidate or a full knee replacement. So then we start talking about the Mako robot for knee replacements. Now, this is where it all started. It started with the partial knee replacements and has since been adapted to both total knee and total hip. It's been around for over 14 years, 850 plus systems, 145 and growing peer-reviewed studies. Over 300,000 procedures have been performed, and this is just through 2019. This is growing exponentially as well. So how does the total knee replacement for the Mako work? I'll let this video describe it. It's very similar to the hip, but you'll see some differences.
Let's take a look at how it works. It begins with a CT scan of the knee joint. A CT scan is virtual model is loaded into the Mako system software and is used to create the personalized preoperative plan. Prior to surgery, the surgeon reviews the plan size and placement of the implant, and if necessary, modifies the preoperative plan in order to better position the implant to the patient's unique anatomy. During surgery, the surgeon locates points on the knee in order to register the anatomy in the Mako system. This process establishes the relationship between the patient's actual anatomy in the operating room and the 3D model that was used during the planning process. This step helps ensure the procedure is executed to plan. Once the anatomy is registered to the 3D model, the surgeon has the flexibility to modify the preoperative plan based on their assessment of the patient's anatomy and range of motion. Then, the surgeon guides the robotic arm to remove the arthritic bone and cartilage from the knee. A virtual boundary provides tactile resistance to prevent the surgeon from removing more than just the arthritic bone identified in the preoperative plan. And visual cues, shown in green, appear on screen to show how much bone to remove. Collectively, these cues help the surgeon stay on the preoperative surgical plan. With the diseased bone gone, a knee implant is inserted into the joint space. And once the surgeon is comfortable with the knee's movement, it's off to the recovery room to begin the journey towards strengthening the knee joint.
Am I muted so you can hear me? All right, perfect. So hopefully y'all heard that video. That was just kind of a run through of how the Mako robotic total knee works. So again, can't stress enough, the personalized preoperative surgical plan is kind of the meat and potatoes. I'm able, again, to map exactly where the bone is. I can put my implants exactly where I want them to be to give the knee the most natural, most anatomic fit for what the native knee would be. And then in the operating room, I'm able to use the robotic arm. Where it comes in is to keep me in a boundary. So I'm only able to remove what I want to remove. only able to take what I want to take, nothing else. That allows me to place the implants to within a millimeter of what my plan was. Then, after I've placed my implants, I can test it in real time to see what the balance of the knee is. Is one side too tight? Is one side too loose? How's the flexion? How's the extension? How is it working? Able to, in real time, see how the knee is functioning to get the best, most natural feeling knee possible. And then once again, the implant is placed exactly how I want it to be. That's the best part, I think. I'm able to take from step 1, the personalized surgical plan, to step 4 here on this slide is implant placement. So from the beginning to the end, it's within a millimeter of where I want it to be. The technology is tremendous in terms of allowing me to have a plan, execute the plan, and have the best functioning knee as possible. Multiple clinical studies have looked at this, looking at total knee, lower pain scores using the Mako robot, quicker recovery for the partial knee. Once again, the partial knee is where it all began, and it's a tremendous value, a tremendous technology in terms of placing that partial knee replacement exactly where you want it to be. And then the total hip as well, the replication of the feeling of a natural hip, a normal hip, and even a normal knee as well. It's all because I'm able to find the patient's anatomy, make a personalized plan, and place those implants exactly where we want them. And then we have real-time feedback. There's no guesswork. We're able to see exactly what the knee is going to function like, so we know what it's going to be post-operatively. And if I leave you with one thing, I think it's this slide. There's no guesswork. It's hitting the bullseye every time. That's what we should all strive for. That's what we all want. We want the patients, obviously, to have the best outcomes. And the ability to do that certainly is made easier by this technology. Once again, preoperatively, you get the CT scan, map out exactly where everything is, all the way to the finished product where you nail the bullseye, and you nail it every time. And I think that certainly is the reason why knees and hips, are feeling better, getting more natural feeling. The mechanics are better, the outcomes are better. So with that, I think we are done with me talking. Certainly we can open it up to a couple of questions if anybody has any. And then once again, like I said, we can, if anybody's questions don't get answered, we can send out some answers. All right. Can everybody see me? Is this your question? Perfect. So first question was, please explain the cause of a very painful knee valgus and whether knee replacement is the only option to correct it. Great question. So it kind of depends. Biggest thing I would say is, what is the age of the patient? So we do see genetic causes of knee valgus. Knee valgus just is another word for kind of knock-kneed, where the knees are pointing out. There are genetic causes. There are certain types of bone dysplasia that can lead to that. And so if you're a very young patient, obviously we do everything we can to keep you a relatively normal knee joint. There's certain operations. Osteotomies are kind of a way to treat certain types of deformities. An osteotomy just means you actually cut the bone, move it where you think it probably more normally needs to be, and then fix it and allow it to heal in those positions. That's kind of a good treatment option for the right patient. If the knee is in valgus, or again, knock knee, because of arthritis, then certainly knee replacement is probably the only option at that point. And there are tremendous outcomes from knee replacement for the right patient with knee arthritis. Hopefully that answers that question. Another question looking at hips was, how do you know when it is time? Is there a point when you are doing damage even though you can still function? Great question. I hear this all the time. What I like to do is I throw it back to the patient. So when they say, "Doc, when is it time?" I say, you are the driver of that. You tell me. The reason I say that is because everybody's a little bit different. Some people have expectations that they want to do activity A, B, and C, where the others are just looking for maybe just pain relief or whatnot. So I always think the patient knows when it's the time. What I like to say, though, we go through that list of questions we went through before. Again, is it waking you up from sleep? Are you not able to do the things you want to do anymore? Is it precluding you from activities of daily living? You can't get even to the the mailbox anymore. You can't get to the store. You can't play with your kids and grandkids. Those are all types of things where we say, yeah, certainly if you're ready for it, it's the time, because this is an operation that could significantly benefit you. Is there a point when you're doing even more damage? Well, technically, yes. We know the natural history of arthritis is that it certainly declines over time. You definitely have a little bit of an ebb and flow. Sometimes it gets a little better as you're treating the inflammatory symptoms with medicines or injections. It gets a little better, and then arthritic flares occur. It kind of gets a little worse, gets a little better, gets a little worse, but we know the natural history is kind of a downward trajectory. So technically, the process, once it's started, it will certainly continue. Everybody's a little different. Sometimes knees and hips go bad over the course of a year. Sometimes they take 15 years. Everybody's a little bit different. But we do know kind of the natural history is that there is a slight decline. In what ways is a total knee compromised? I'm not sure. Compromised?
Compromised.
Total knee compromised versus a normal knee. Not entirely sure what that question is asking. Basically, the knee is a knee versus a total knee. Again, we don't take your knee, throw it out, and put a new one in. It's purely a resurfacing. If you're going to use the analogy again of tires, the wheels are the bones and the rubber tire is the cartilage. Eventually the rubber tire gets worn out. You got to put new tires. You got to resurface those wheels. It's the same with a knee replacement. What we do is we make very precise fine cuts around both the femur and tibia. And then to those, we place a metal cap similar to how a dentist places a crown on a tooth. You keep your bones, you keep your ligaments, you keep your muscles, you keep your tendons, everything. It's your knee. It's just a resurfaced knee where we remove all that pain-generating damaged cartilage, damaged bone, and we resurface that with a metal cap. And then that piece of plastic is in between the two that allows the knee to function. Similar to a hip, we remove the diseased arthritic bone and cartilage, and we resurface the socket with a metal cap, piece of plastic between, and then there's a pin going down the thigh bone with either a metal or ceramic ball. So it's a little bit of a different thing than a knee, but certainly you keep all your muscles and ligaments and all of that. Yeah, a little bit. Yeah.
That second one, pretty straightforward.
Is there a point at which either cannot be replaced because of level of damage? No. So I'll tell you, technically, from a surgical standpoint, it can get harder, but there's not really a point which it can't be replaced. Now, getting into, again, a little bit of the technicality of the surgery itself, the farther along something goes, the more potentially deforming forces there are. Makes it our duty to kind of change the implants slightly. So we start talking about potentially more revision style components with a little more constraint. There are certain levels to joint replacement, from very, very basic to very, very complex, and certainly gray areas in between. But it doesn't typically get to a point that it can't be done. It just gets harder both for the surgeon and for the patient, I'd say. Another question here, it just says, I had a robotic knee over 6 months ago, had a manipulation around 6 weeks. I still have pain. I did all the PT and also worked out on a bike. What could have gone wrong? Well, that's definitely a great question. It's a question that would require a lot of investigation. Certainly, without seeing the x-rays, seeing the knee, seeing a physical exam, it's a little hard to determine kind of where you are in terms of the recovery standpoint. Sometimes joint replacement can take up to a year to kind of sort itself out. So there's some ebbs and flows. Everybody, again, is a little bit different in how they do. But certainly something we'd love to look at and see if you want to give us a call, we can certainly check it out. What is the normal recovery time frame or hospital stay? Everybody, again, is a little bit different. We're doing a lot of these operations even as outpatients. So with a partial knee replacement, I'd say at least 75% of folks are going home same day. Again, with the robot, it makes for less soft tissue dissection, less invasiveness. So the surgeries go a little bit quicker and a little bit easier on folks. My standard for hips and knees is usually a one-night stay. It's a kind of an overnight just to keep an eye on everyone, make sure they're doing well. You work with physical therapy right away. You get up that same day and work. Next day you get up, go for a walk, and then go home. And probably 98% of people are going home. We used to send a lot of folks to rehab facilities, but we found that the operations are going so much more smoothly, and pain control is so well done nowadays that people do very, very well at home. In fact, they do much better at home. You get the family to care for you, and you get your own food, your own bed. Everybody does quite well that way. In terms of how long does it take to recover, again, everybody's a little bit different. I say for the first 6 weeks, you're taking it slowly, going for walks, going to the store, doing what you need to do, and working on getting the knee physical therapy in terms of range of motion. And then by about 3 months, you're back doing pretty much whatever you want to do. Are you able to get back to full range of motion in a knee, and can you squat? So yes and yes. Range of motion, the knee replacement especially is primarily done for pain relief, but you certainly gain motion typically from what you are pre-op. And that's because of a lot of times there's bony deformity, there's big bone spurs that are kind of holding up the range of motion. It's painful to move. So we certainly aim to get you more range of motion during these operations. You can certainly squat. You can do as much as you want, whatever you can tolerate. And so I'd say I do have certain people who definitely get back to doing some pretty substantial activities, some substantial exercises. Skiing, obviously, up north here is a big one. People love going back to that. Golf, when it's nice, this is another really good one to do. Any more? That's good. So I think that's all the questions, unless anybody else has any final pieces of information they'd like to hear about. Hopefully this was informative. I hope, again, thank you very much for coming. And this hopefully worked out. We got through our technical glitches, and you were able to learn a couple of things about robotic surgery and how the Mako robot has certainly been improving, I think, the ability for precision. If I would leave you with one thing, I think it's the preoperative plan all the way to implant placement is exactly what we want it to do, no guesswork. And we're trying for that 100% accurate at all times. So once again, thank you so much, and look forward to hearing from you.